Hello, welcome everyone to the EMT COVID-19 quarantine lecture on chest injuries, chapter 29, page 1031. So let's go ahead and get started. Looking on the introduction, your book says chest trauma causes more than 700,000 emergency department visits and more than 18,000 deaths in the United States each year. These injuries can involve the heart, lungs, and the great blood vessels, and may result of blunt trauma, penetrating trauma, or both. We as EMTs must treat any injuries that interfere with the body's mechanism of normal breathing without delay. Internal bleeding can collect in the chest cavity, compressing the lungs of the heart, and may collect in the chest and prevent the lungs from expanding. Alright, so next let's do a quick review of the chest, looking under anatomy and physiology. So first, we must know the difference between ventilation and oxygenation. Ventilation is simply the body's ability to move air in and out of the chest and lung tissue. Oxygenation, on the other hand, is the process of delivering oxygen to the blood by diffusion from the alveoli following inhalation to the lungs. Alright, if you'll turn over and look at page 1032, figure 29.1, you'll see that the chest, or the thoracic cage, extends from the lower end of the neck to the diaphragm. So a penetrating injury to the chest may also penetrate the lungs and diaphragm and injure the liver or stomach. Thoracic skin, muscle, and bones has similarity to skin, muscle, and bones in other regions. And if you'll look at the bottom, right above figure 29.1, where it says very young children, the intercostal muscles are not yet developed. Children therefore have a tendency to breathe with their diaphragm. That's why they're called belly breathers. Go ahead and highlight that because you will more than likely see that again. Alright, moving on along, the neurovascular bundle is a network of nerves, arteries, and veins lying closely along the inferior of and slightly posterior to the lowest margin of each rib. They can be a source of significant bleeding into the pleural space. The pleura covers each of the lungs and thoracic cavity. Parietal pleura is the inner chest wall lining, and visceral pleura is basically what covers the lungs. Surfactant, which is pleural fluid between the parietal and visceral fluid, it allows the lungs to move freely against the inner chest wall during respiration. The ribs are connected in the back to the vertebrae and to the front to the sternum. The thoracic cage contains the heart and great vessels, the aorta and the right subclavian arteries and their branches, the pulmonary arteries, and the superior and inferior vena cava. The mediastinum is the central part of the chest containing the heart, great vessels, esophagus, and trachea. A thoracic dissection, which is basically the severing of an artery, can develop in this area of the chest. The diaphragm is a muscle that separates the thoracic cavity from the abdominal cavity. Alright. Moving on to page 1033 under mechanics of ventilations. Looking down at figure 29.3, you'll see that the intercostal muscles, which are between the ribs, contract during inhalation. The diaphragm contracts or flattens at the same time. The interthoracic pressure inside the chest decreases, creating a negative pressure differential. Air then enters the lungs through the nose and through the mouth. Then the intercostal muscles and diaphragm relax during inhalation and allow air to be exhaled. Alright, if you'll look over the second side of page 1033 where it says, note that the nerves supplying the diaphragm, the pharynx nerves, exit spinal cord at C3, C4, and C5. Go ahead and highlight that. And if you'll look at figure 29.4, you'll see the patient whose spinal cord is injured below C5 may lose the power to move his intercostal muscles. The diaphragm should still contract and the patient will still be able to breathe because the phrenic nerve remains intact. All right, page 1034. The minute ventilation or minute volume is the amount of air moved through the lungs in 1 minute. It is calculated by multiplying the normal tidal volume by patient's respiratory rate. Example on page 1034 will show exactly how to calculate that. Patients with decreased tidal volume will have an increased respiratory rate. A 1,000 to 1,500 milliliter bag valve mass may overinflate the lungs, causing gastric distension and impair lung function. That can reduce cardiac output and potentially worse chest injuries, such as a pneumothorax. Rapid respirations can cause acid-base imbalances and blood-gas imbalances. All right, page 1034, where we talks about the injuries of chest. If you'll go ahead and look at the word closed chest injury and highlight its definition where it says this type of injury is generally caused by blunt trauma. So basically there are two types of chest injuries, open and closed. So first we'll talk about closed chest injuries. This where the skin is not broken. And once again, it is generally caused by blunt trauma. Often cause significant contusions in cardiac muscle, which is basically cardiac contusion, and lung tissue, pulmonary contusion. If the heart is damaged, it may not be able to refill or receive blood. That results in cardiogenic shock. Lung tissue bruising can result in a loss of surface area and decreased oxygen and carbon dioxide exchange and cause hypoxic and hypercarbic states. Rib fractures can lacerate lung tissue and cause further vessel damage with each chest wall movement, and that can rapidly lead to hypovolemic shock. In open chest injuries, an object such as a knife, bullet, piece of metal, broken in or fractured rib penetrates the chest wall itself, causes instant damage, but symptoms develop over time. Excuse me. An impaled object will always remain in place. You should never attempt to move or remove the object. If you remove that object, that will cause heavy bleeding, and it could cause damage during its removal. Now, blood trauma to the chest may fracture the ribs, sternum, and chest wall, bruise the lungs and heart, and even damage the aorta. Almost 1/3 of people killed immediately in car crashes die as a result of a traumatic rupture of the aorta. And you'll see that over on page 1035. Go ahead and highlight that. And vital organs can be torn from their attachment in the chest cavity, causing internal life-threatening bleeding. All right, moving on down to signs and symptoms of chest injury. These are very good signs and symptoms to know and remember, and highlight. I would definitely highlight the next to the last one where it says rapid, weak pulse, and low blood pressure. That is the principal sign of hypovolemic shock, and it can result from extensive bleeding of lacerated structures within the chest cavity. All right, patients with chest injuries often have tachypnea, which is rapid respirations, and shallow respiration because it hurts to take a deep breath. The patient may not actually be moving air due to chest wall trauma, so you should auscultate multiple locations on the chest wall to assess for adequate breath sounds. All right, moving on along to page 1036. Your patient assessment will always be the same, beginning with scene size up. Of course, you know scene size up. You got BSI. Make sure you're safe or use and your partner. Then you want to evaluate the mechanism of injury. Chest injuries are common in motor vehicle crashes, fall, industrial accidents, and assaults. Then, of course, you want to consider C-spine. Next, you want to perform a primary assessment, form a general impression, and you want to address life-threatening hemorrhage immediately, even before airway concerns. So always remember that. And then you want to note the patient's consciousness. Then you'll move down to airway and breathing. You want to ensure the patient has a clear and patent airway. Normal breathing should always be effortless, and any deviation from this pattern should be called for concern. Consider need for cervical spinalization when blunt trauma is present, and note whether jugular veins are distended. And that will be a sign of tamponade pressure or tamponade on the heart. And you want to determine whether the patient is breathing, if the patient's breathing is present and adequate. Inspect for decap BTLS. Then you will look for equal expansion of chest wall. That would indicate a loss of muscle function. Check for paradoxical motion and abnormality associated with multiple fractured ribs. And you want to apply an occlusive dressing to all penetrating injuries to the chest. If breathing is inadequate, you want to provide positive pressure ventilations, but do not ever use positive pressure ventilations on patients who have a pneumothorax. You want to be alert for decreasing oxygen saturation, which can lead to hypoxia, and you should be alert for signs of impending tension in pneumothorax, and we'll talk about that in just a minute. And under circulation, you always want to assess the pulse. If the pulse is too fast, too slow, if the skin is pale, cool, or clammy, consider that patient to be in shock. And of course, you'll make your transport decision. Priority patients are those who have a problem with the airway, breathing, and or circulation. And you want to pay attention to subtle clues such as appearance of the skin, level of consciousness, and these patients will have a sense of impending doom in their face. All right, and moving on to page 1038, look at table 29-1. You'll see the deadly dozen chest injuries. These are considered very deadly for chest trauma patients. They are life-threatening and they must be identified immediately. Look at the first 9. Those first 9 must be identified and managed during your primary assessment. The last 3 can be identified during the secondary assessment. All right, and looking on the history taken, you always want to investigate the chief complaint. Verify where the pain is located in relationship to the area being touched. Equal expansion of the chest and movement of the rib cage and the diaphragm can confirm that there is nerve conduction to that region of the body. All right, then you want to get your sample history. You want to focus on the MOI and find out these important questions. A, speed of vehicle or height of fall. B, the use of safety equipment. C, the type of weapon used. And D, number of penetrating wounds. All right, moving on down, page 1039, secondary assessment. You want to do your physical examination for isolated injury with limited mechanism injury. Focus on the isolated injury. Patient's complaint, body region affected. Ensuring wounds are identified and bleeding controlled. Location and extent of injury. Access all underlying systems. Anterior and posterior aspects of chest wall, and be alert to changes in the patient's ability to maintain adequate respirations. Look for significant trauma likely affecting multiple systems. Start with a rapid physical examination, and you always want to use decap BTLS to determine the nature and extent of the thoracic injury. Alright, in vital signs, you always want to assess the pulse, respiration, blood pressure, skin condition, and pupils, and reevaluate the patient every 5 minutes or more. A rapid pulse or respiratory rate may indicate that chest wall injury is causing a decrease in available oxygen, which is hypoxia, or blood loss resulting in decreasing red blood cell, which is hypoxemia. Increased work of breathing can be identified by the use of accessory muscles in the face, neck, and chest. Pulse and respiratory rates may decrease in later signs in chest injury. Alright, page 1040, under reassessment, you want to repeat the primary assessment, reassess the chief complaint. Then you want to always reevaluate the airway, breathing, pulse, perfusion, and bleeding. Then you want to perform your interventions, reassess vital signs, observe trends, provide appropriate spinal stabilization for patients who have blunt trauma with suspected spinal injuries, maintain an open airway and be ready to suction this patient, and consider an OPA or NPA, control significant visible bleeding and provide high flow oxygen, and place an occlusive dressing over penetrating trauma to the chest wall, provide aggressive treatment for shock, and transport rapidly. Do not delay transport to complete non-saving life treatments. These can be performed en route to the hospital. Alright, and lastly, communication and documentation. Communicate all relevant information to the staff and receiving hospital and describe all injuries and the treatment given. And with that being said, I'm going to take a break and I'll be right back.